Good afternoon, good evening, wherever you are. And it's my pleasure to host Dr. Ali Aminyan for the main event, talking about cardiovascular in patients with type 2 diabetes, comparing metabolic surgery versus the usual care, the article that we've been talking about for the past 2 to 3 weeks. Ali is one of the main contributors to the communication committee, an active member, and a contributor to the bariatric surgery world with all the studies that they do at Cleveland Clinic. Glad to have you, Ali.
Thank you, Ahmed, and thank you, IFSO, for the opportunity to present this important study. I'm going to present about 10-15 minutes the data that we published in JAMA, and then I think we can have some time for the question and answer. So the title is Cardiovascular Outcomes in Patients with Type 2 Diabetes and Obesity, and we compared metabolic surgery versus usual care for Type 2 diabetes. Okay, in terms of background, we know that in patients with obesity and type 2 diabetes, cardiovascular disease is the main cause of morbidity and mortality. We have almost 12 or 13 randomized clinical trials that consistently showing significant effect of metabolic surgery on excess weight and cardiovascular risk factor control, including diabetes control. However, the small size of the randomized clinical trials has precluded investigation on the effects of metabolic surgery on major cardiovascular outcomes and survival. So that's why we did this study to show to see if bariatric surgical intervention would be associated with reduction in incidence of major cardiovascular events. So this is a retrospective MASH cohort study in patients with obesity and confirmed type 2 diabetes who underwent metabolic surgery or received usual care for their diabetes within the Cleveland Clinic Health System between 1998 and 2017. So key inclusion criteria were aged between 18 to 80. All patients were obese with BMI of 30 or above, and they had HbA1c of 6.5 or greater. So we identified 2,287 surgical patients, and we were propensity matched them 1 to 5 with control patients, which led to 11,435 control patients who received usual care for their diabetes and obesity. Patients were followed through December 2018, and in addition to the propensity matching, we did fully adjusted Cox proportional hazard regression models to reduce any potential impact of residual confounding on the findings. We did cumulative incidence estimate. We calculated that for each outcome, and we reported those. The pre-specified primary endpoint of a study was a composite endpoint. First occurrence of extended major cardiovascular events, including all-cause mortality, coronary artery events, cerebrovascular events, heart failure, atrial fibrillation, and nephropathy, composite of 6 major cardiovascular outcomes. And we had 7 pre-specified secondary endpoints. One was composite 3-component MACE, which was a composite of all-cause mortality, myocardial infarction, or ischemic stroke, and we had 6 individual secondary endpoint, which were first occurrence of each of the 6 components of the primary endpoint listed above. So in terms of the surgical procedures, 95% of patients underwent either gastric bypass or sleeve gastrectomy at that time period. This table shows the baseline characteristics of the patient. In the metabolic surgery group, median age was 52, 65% were female with a median BMI of 45, 85% had hypertension at baseline, 34% were on insulin with median A1C of 7.1% at baseline and a median GFR of 90. So this is the most important slide of the study, the primary endpoint. As you see, over the course of 8 years, in the metabolic surgery group, the cumulative incidence of 6-component MACE was 30% in the surgery group versus 47.7% in the non-surgical control. So metabolic surgery was associated with 17%, almost 17% reduction in rate of 6-component MACE over the course of 8 years. That led to hazard ratio of 0.61, which was highly statistically significant. In terms of the secondary endpoints, composite secondary endpoint of the study, 3-component MACE, again, 3-component MACE occurred in 17% of metabolic surgery patients versus 27.6% of the control group over the course of 8 years. So surgery was associated with 10.6% reduction in 3-component MACE over the course of 8 years, which was highly statistically significant with hazard ratio of 0.62, favoring metabolic surgery. For the individual outcomes, all-cause mortality happened in 10% of surgery group versus 17.8% of non-surgical group over the course of 8 years. So absolute risk reduction, absolute risk difference was 7.8% over the course of 8 years, favoring metabolic surgery with hazard ratio of 0.59, which was highly statistically significant. That means if we operate on 13 patients over the course of 8 years, we can save 1 life based on the findings of this study. The effects on heart failure was striking. Over the course of 8 years, surgery was associated with 6.8% cumulative incidence of heart failure versus 18.9% in non-surgical group. Hazard ratio 0.38, which was highly statistically significant. Similar finding on coronary artery disease with hazard ratio of 0.69 and the cerebrovascular disease with hazard ratio of 0.67. Both were statistically significant, favoring metabolic surgery compared to the non-surgical controls. The impact on nephropathy was impressive. 6.1% risk of nephropathy over the course of 8 years versus in surgery group versus 16.3% in non-surgical group. Hazard ratio of 0.4, favoring metabolic surgery, which was highly statistically significant. And for atrial fibrillation, the hazard ratio was 0.78, favoring metabolic surgery compared to a non-surgical group. So, and then we looked at the effect of surgery on the weight and HbA1c. As you see here, over the course of 8 years, surgery was associated with almost 15% greater reduction in body weight or 20 kilogram weight loss, more weight loss compared to non-surgical controls. And in terms of effects of surgery on the A1C, we see that metabolic surgery group had 1.1% lower A1C compared to the baseline, compared to the non-surgical control group over the course of 8 years. And then we looked at the diabetes and cardiovascular medications over the course of the follow-up in this matched cohort study. We observed significant reduction in the need for insulin and non-insulin diabetes medications after metabolic surgery. In addition, significant reduction in the use of antihypertensive medications, including renin-angiotensin system inhibitors and lipid-lowering medication, were observed after metabolic surgery over the course of this study. And then we did subgroup analysis for primary endpoint of the study to see if these findings were consistent in key subgroups of the study. And we found that the results were consistent across the key subgroups. For example, it doesn't matter if if the patient is male or female, age over 54, under 54. More importantly, if the patient is BMI over 40 or under 40, or being on insulin or not. In all these subgroups, we observed the positive effects of the metabolic surgery for the primary endpoint of the study compared to the non-surgical control groups. Obviously, surgical intervention was associated with some complications, some adverse events, but in most parts, the adverse events were mild and were not very frequent. So over the course of 8 years, 2.9% in the surgical group needed total parenteral nutrition, 52% had endoscopy, and about 14% had abdominal surgical procedures, about 10% needed cholecystectomy over the course of 8 years. This table shows average change in nutritional variable from baseline in surgical versus non-surgical patients. And as you see, the nutritional complications were modest for the most part. Over the course of 8 years, the difference between the surgical and non-surgical group in the albumin level and hemoglobin level was only 0.2 gram per deciliter lower in the surgical patients compared to the non-surgical patients. So this study has limitations. This is not a randomized clinical trial, it's an observational study. Therefore, residual measured and unmeasured confounders can influence findings in this study like any other observational studies. However, we did a sophisticated sensitivity analysis to address that. We repeated our analysis in 15 different non-surgical cohorts and to show that if the results are consistent, and the fully adjusted Cox model showed that the results in all 15 cohorts are consistent. We also calculated time-varying hazard ratios and e-values for the study endpoints, and the findings of sensitivity analysis indicate the robustness of our findings. Coding error, misclassifications, misdiagnoses in data coming from the EHR is recognized issue with this type of a study. We couldn't identify the exact cause of mortality, and we used the all-cause mortality as one of the study endpoints. We did not compare surgical procedure on this study, gastric bypass and sleeve gastrectomy, head-to-head, because that was not the primary intention of this study. And importantly, less than 10% of non-surgical patients were exposed to new diabetes medications, including GLP-1 agonists and SGLT2 inhibitors, which are known to have favorable cardiovascular benefits. In conclusion, among patients with type 2 diabetes and obesity, metabolic surgery compared with non-surgical management was associated with a 39% lower risk of 6-component MACE. Surgery was associated with a 38% reduction in a narrower 3-component MACE, including mortality, MI, and stroke. Metabolic surgery was associated with a striking 41% lower risk of all-cause mortality. And we found that all 6 components of the primary endpoint, including mortality, coronary events, cerebrovascular events, heart failure, atrial fibrillation, and nephropathy, contributed to these results. As you probably know, the findings of the study was published in JAMA last month, and it's available if you're interested to have more details about the study. Thank you very much, and I'm happy to get questions.
Thank you very much, Ali, for this comprehensive explanation and presentation. You almost described everything that was in the article itself. To the audience, please type in your question in the question section if you have anything, any questions at all to Dr. Amignan. Ali, I'm gonna start asking you a few questions. Um, in the setup of the study, you set the index dates a little bit differently in the surgical versus the medical group. Is there a reason why not start at the same date?
So when we do the study like this, so for the surgery group, the index date is obvious, is the date of surgery. But for the medical patients, we have to assign a date and then follow the patients from that date moving forward. So we randomly assigned, so we had a cohort of almost 300,000 diabetic patients in Cleveland Clinic Health System who did not have surgery. So we got the surgical date in the surgery group and randomly assigned them to patients in the to those 300,000 patients base cohort. We randomly assigned those data to those patients, and then we check those patients to see if those patients at that random assignment had met the inclusion exclusion criteria of the study. If they had if that random assigned date they had exclusion criteria of the study, we excluded them. If they had inclusion criteria, we included them. So by doing that, we repeated that 15 times, and we developed 15 different cohorts of the medical arms. And then we showed that the baseline characteristics of those 15 cohorts were relatively similar at that index date, which was randomly assigned to each patient in each cohort. And then we chose randomly, we chose one of those 15 cohorts for the main analysis and reserve the other 14 for the sensitivity analysis. So to answer your question, the random date is the index date got from the surgery and were randomly assigned to non-surgical patients because we needed time 0 for non-surgical patients to follow them. So it was not exactly the same date, but shouldn't affect the analysis, because we took care of that when we did fully adjusted Cox models. The statistical analysis could take care of this small difference between these two index dates.
Okay. Now, a couple questions from the audience. Actually, my friend and colleague, Dr. Ashraf Haddad and Dr. Jose Antonio Lopez, both of them are interested in the subgroup analysis of the BMI 30 to 35. Especially that, one of the observations that were raised by Dr. John Dixon in the IFSO is that this group who has type 2 diabetes have actually higher mortality with weight loss, but no actual studies were done on bariatric surgery. Did you observe any difference in that group? Did you do that analysis, Ali?
That's a very good question. I'm trying. So we reported the subgroup analysis in the supplement of this study. Let me see if I can find out for you. So about 5% of patients had BMI under 35. So 95% of patients had BMI over 35. So since the sample size was small, we could not check the effect of surgery versus non-surgery on cardiovascular outcomes, but we could show the effect of surgery on the A1C and diabetes medication. Can you see my screen now?
Yeah, we can.
Yeah. So in the as you see here, the effects of the surgery on the A1C, you see in patients with BMI over 35 and under 35, and that's the control group, BMI over 35 and under 35, and you see that we see a nice drop in the A1C curve over the course of the years, and similar finding in terms of reduction in the need for non-insulin diabetes medication over the course of 4 years. The problem was that only 5% of patients, about 150 patients in the surgical group, had BMI under 35. The sample size was not large enough to examine the effect of the procedure long term. That's why we couldn't do that analysis. But we could show that there was significant reduction in A1C and diabetes medication in low BMI patients after metabolic surgery.
Well, that is great. Thank you, Ali. And this is one of my actual questions. The other aspect of the methods in matching patients, you matched certain criteria but could not match the rest. And this affected some of the variables like smoking, aspirin, and older age, as well as black race in the medical group was a little bit higher. Do you think that affected the results by any chance? I know you alluded to it in the presentation.
Yeah, so we used 7 factors for propensity matching, 7 factors that could potentially be confounding, including age, BMI, index date, location, whether in Florida or Ohio centers, presence of diabetes complications, and being on insulin or not. And we propensity matched to 1 to 5 to make similar cohorts. But as you mentioned, after matching, some factors were different, some favoring metabolic surgery, some favoring the non-surgical cohorts. For example, the frequency of hypertension and dyslipidemia was higher in the surgical group. However, smoking was more prevalent in the non-surgical cohorts. But as I mentioned, we, in addition to matching, we then did the adjusted regression models to reduce any potential impact of residual confoundings on the findings. So it was not just the propensity matching. So the goal of the propensity matching was not to make both groups 100% the same. The goal was to make the groups very similar, and we know that there are some differences. That's why we did it adjusted regression, and in the regression models, we included all between 25-30 variables, baseline variables, to eliminate or to decrease the risk of confounding. And then, as I mentioned, we had comprehensive sensitivity analysis. We repeated our findings, different cohorts, different ways in sensitivity analysis to address the impact of possible residual or unmeasured confounding. And the findings in sensitivity analysis show the robustness of the primary study findings.
And you know, looking at the outcomes, one would think early on, you know, just because patients are undergoing an intervention, the mortality of the surgical group early on would be a little bit higher as compared to the medical group. But you did not notice that in your results. Can you elaborate what message does that send?
So these procedures are very safe. The mortality rate is very low. This study was the study was done like 10 years ago. The patients had surgery about 10 years ago, and at that time, mortality rate was higher than the mortality rate we see these days. So the current mortality rate of the procedure, these procedures, is about 1 in 1,000 or 1 in 2,000 patients. So the field is improving. The mortality rate is so rare. As you see here, that's the mortality graph. So we see in the first year, the mortality rate of both groups were similar, graphs were parallel. And after a year, we see that the graphs are separating. So that means that the effect of the surgery would be very quick. So after a year or so, by reducing large amount of weight and controlling the risk factors for cardiovascular disease, then we can have survival benefit after metabolic surgery. So by year 2 for year 4, we see that the curves are largely separated, and I think that's great. That's great benefit. In the initially, as you mentioned, you see there is a small increase in mortality in the surgical patient, probably because of early post-op complications and mortality. But over the course of the years, we saw survival benefit in the surgical patients.
That is great. And did you correlate results to the degree of weight loss at any point, Ali? Meaning, if patients achieved higher weight loss, they would actually have less mortality?
It's a very good question. So we did not do that on that study, but we are going to do that to find out the threshold for weight loss based on the medical literature, based on the look ahead randomized clinical trial. So over the course of the 9 years in look ahead, patient lost 5%, 6% of their weight by intensive lifestyle modification, and that could control the cardiovascular risk factors, but it did not affect the mortality. So based on that, we know that 5% weight loss would be good to improve the cardiovascular risk factors, but probably not be enough to decrease the mortality. So that's the second phase of this study that we are doing now to identify the threshold weight loss that might be the cut point to see the cardiovascular benefits. Might be 10%, 15%, 20%. So hopefully we can find that cut point, and then we can share with you.
That's great. And how about blood sugar control and the hemoglobin A1C? Is there a specific cutoff or level of improvement that you looked at? And this is one of the questions from Dr. Marcos Leo as well.
No, we did not. We did not do this correlation analysis in this study. But as I mentioned, by the end of 8 years, we observed 1.1% greater reduction in A1C in surgical group compared to non-surgical patients.
That's also great. And what message does this study send to the medical community, Ali?
So the few messages. One is that obesity or severe obesity, because most of these patients have severe obesity, and type 2 diabetes together can be life-threatening conditions. Over the course of 8 years, 18% of patients in the non-surgical controls died, as you see here. So it's unfortunately very high estimate. So you see a patient with type 2 diabetes and severe obesity, you see you have 2 clinics in a week, you see 40 patients. So then you can estimate that 18% of those patients gonna die in 8 years if they continue their usual care for diabetes. So these are lethal or potentially life-threatening conditions. And if we intervene with a way to have them lose weight and keep the weight off, probably we can save lives. So I think that's important message. Another important message is that if the patient can lose weight and can keep the weight off, the bad effects of diabetes and obesity on cardiovascular health can be reversible. It's not irreversible. So this study shows that we can significantly decrease the risk of bad cardiovascular outcomes by 40%. So that means that these bad effects would be reversible if the patient can lose significant amount of weight. The other message is that for a medical community would be that they need to consider these procedures as a tool for their patients if they have patients with obesity and type 2 diabetes, and have the conversation of having bariatric surgery, metabolic surgery with their patients, and hopefully they can refer more patients to bariatric surgery centers. So we know that not all patients would be candidates for bariatric surgery. So some had contraindications for surgery, but at least the medical community can initiate that conversation, refer the patients, and then the bariatric centers can determine if the patient would be a good candidate or not. So I think those are the main message from this study.
And I completely agree with you, Ali, on this one. And one of the critiques that you mentioned in this paper as well is a little bit higher proportion of incidence of major adverse cardiovascular events within the medical group as opposed to some of the published literature. Do you think the medical community would dissect your medical interventions rather than recommend bariatric surgery? This is one of the fears that we have as surgeons reading this study, and this is one of the things that was mentioned in the editorial as well.
Yeah, so you're right. So as I just briefly mentioned, so these are having severe obesity and diabetes is not a good thing. It can be life-threatening. As you see here in this graph, over the course of 8 years, almost 50% of patients in the non-surgical cohort had one of the 6 components of major adverse cardiovascular events. So almost half of the patients in the non-surgical cohorts had at least one event in the course of 8 years. So that's alarming to me. And remember, these patients had their care in Cleveland Clinic, which is the best cardiovascular center in the United States for the past 22 years. So these patients probably had good access to advanced cardiac care, advanced cardiac medications. And despite having that, we see this large incidence of adverse cardiovascular events. So again, back to my previous comment that these are very life-threatening conditions, and we need to intervene. And previous studies have shown that if we intervene earlier, the outcomes would be better. So I think the medical community should consider that and should have this conversation about the possibility of the surgery with their patients.
And one last question from the audience as well. I know you didn't mention it in the article, but Did you look at different surgery outcomes, Roux-en-Y gastric bypass versus sleeve? And would you recommend one over the other in diabetics? I know you have the individualized metabolic score previously published, but did you look at it within this study?
No, we did not look at that because at the time because first, that was not the primary intention of this study. The goal of this study was to compare surgery versus non-surgery. And the other problem was that of those 2,200 patients, only 700 had a sleeve gastrectomy. Most patients in the available literature had gastric bypass because sleeve gastrectomy is relatively new procedure. But hopefully over the course of next 5 years, 10 years, when we have more long-term data with the sleeve, then we can compare sleeve with the bypass. And remember, if we want to do that, then we have to match control group, separate control group for each outcome. So since we had just one control group that was matched to entire surgical patients, then we decided not to look at these procedures separately. That would require a separate control group for each procedure. So yeah, but hopefully in future, our group or the other group can look at the difference between these two procedures in terms of their impact on major cardiovascular events. But that's a very good question.
And the last question is from Dr. Marcus Leo as well. What do you think about the new anti-diabetic drugs? Did any of the medical community, medical patients have those drugs? And did you look at that subset?
So most of the patients, let me see if I can show you. I should have the breakdown of the
Medications, yeah, in supplement one.
yes, in supplement somewhere here. Yes, you see here, less than, so SGL2 inhibitors, about 2% of patients were on SGL2 inhibitors, and GLP-1 agonist, about 10% of patients are on GLP-1 agonist. Most of patients were on metformin, and as I said, about 33, 34 patients were on insulin. But yeah, so that's the critic to any observational study. And as I mentioned, the data of this study came from 1998 to 2017. At that time, these new diabetes medications were not available. So, and we know that these medications would be associated with 20–25% reduction in risk of major adverse cardiovascular events. But again, the findings that we see, the effect size that we saw in the surgical group was so large, was striking. So 40–45% reduction in the risk of major adverse cardiovascular events. So 60% reduction in risk of heart failure. Almost 60% reduction in risk of nephropathy. So even if we would consider newer medications, then they may have they might have had better cardiovascular outcome, but that shouldn't wash out the positive effect of surgery that we have seen. But that's reality. Although these are great medications, the new medications, but these are not available for all patients.
Sure. And, with that, I think we don't have any more questions. Thank you very much, Ali. Any last words you want to conclude with?
No, I think we covered everything, and thank you for all these thoughtful questions. I think the last word would be obesity week in 3 weeks, and we did secondary analysis of this data, and we made risk calculators for based on these outcomes for patients who were in the medical arm versus surgical arm. So that would be very useful in clinical practice. So I'm going to present the risk calculator in 3 weeks in obesity week. So when you have a patient in the clinic, you can put these numbers plug in and in the calculator, and the calculator is going to show you in 10 years what would be the risk of mortality, what would be the risk of heart failure or nephropathy if you continue with medical management or if you get the metabolic surgery. And I think that would give patients evidence-based message about the future risk of adverse cardiovascular events for individual patients.
That is one amazing tool. Thank you, Ali. Keep doing what you're doing. And maybe we can present that risk calculator in What You Missed in Obesity Week for those. We're going to have it in December. Next week, we're going to have the webinar, What You Missed in IFSO. You're going to see me and Ali again next week. So remember to join in our next webinar where we're going to present a lot of studies that were actually presented in IFSO Madrid. Looking forward to having you all then. Thank you, Ali. Thank you, everyone, for joining, and see you next week.
Thank you. I appreciate that.
Thank you.